I'm very excited today to present this case study and talk more broadly about some of the concepts in algorithm bias that we've presented and that we've been referencing throughout the course. A very important topic and something that is one of our key objectives that we hope you all will understand and be able to take away from this course. So here you can find my relevant disclosures. So we'll start with a more broad discussion of what we've been talking about with AI in medicine. So broadly, the promise of AI is that it's going to make not just radiologists but doctors, healthcare providers throughout the medical field better, faster, safer, more efficient, and this is going to be something that can augment the role and the capabilities of the practicing physician. And these tools are becoming more and more necessary as physicians are having to deal with increasing volume, increasing workload, and just the complexity of medical care has increased substantially in the past few decades. So we are kind of at a crossroads that we really need something to be able to meet the demands of modern medical practice, and AI is one of the tools that we hope that we can point to that's going to be able to help us to rise to the challenge. So in radiology, we've already talked about some of the ways that AI can optimize workflow, increase accuracy, and improve the radiologist's quality of life. But for all of the promises that we have for AI for use in high resource centers and high income countries, there's even more potential for AI for use in radiology in low and middle income countries. Now, this is something that can augment the role of the physician and increase the capability of the physician, and particularly the radiologist who's interpreting studies. So in areas that don't have as developed as of a healthcare education system, that don't have as many education mentors, resources, and don't have as much accessibility to subspecialty care, these AI applications that are able to enhance the diagnostic capabilities of the radiologist can help a more general radiologist perform and interpret studies at the level of a subspecialist. So helping to level the playing field and level the potentially the knowledge gap between a more general radiologist and a subspecialty trained radiologist. These tools that can automate and triage exams are especially helpful when there's a very large backlog of exams that have to be read, and especially in areas that are very underserved in radiology, that have a very large catchment area, that are serving a very large patient population, but have relatively fewer radiologists to perform these duties. This is important to be able to recognize those studies that need to be interpreted more urgently. And then, of course, these AI applications that can optimize imaging protocols and improve image quality, especially on scanners that may have outdated protocols, maybe older scanners to begin with, being able to generate higher quality images, potentially from lower quality or suboptimal data, would also help to improve the diagnostic capability of the interpreting radiologists. But this is a double-edged sword. So the AI applications that are in use and are being developed historically have underrepresentation of data from low and middle income countries when they are developing their algorithms. So in their training data, this information, these images typically come from higher resource centers, high income countries. And not to say that this is necessarily an intentional bias that's being built in. This is just by the nature of where more exams are being performed, where more training data is available. This is coming from countries and from regions that have more infrastructure and have more CT scanners, more high resource healthcare centers that are performing these exams and make them available for training. And this problem really mirrors some of the historical inequities that we have in the development of pharmaceuticals and medical technologies, that these are typically developed and trained in high resource centers in the high income countries, and this can result in disparities in differential performance between populations in these higher resource settings, and then getting out into other regions of the world. And when we talk about or when we've talked about the importance of a diverse data set and having a robust algorithm, this is because we know that when the algorithms get out into the general population, they are going to be challenged by different types of data that they've not encountered before. So a strong, robust, generalizable algorithm is going to be one that can respond well to these new types of exams that are coming from different scanners, coming from different patient populations. But those that perhaps are weaker, or those that are prone to algorithm bias, could potentially result in a worse performance on these different patient populations, and could perpetuate and deepen some of the existing health disparities that already exist. So we'll dive into algorithm bias a little bit further. So just as a reminder, algorithm bias is the differential performance of an AI algorithm between different patient groups. This is notoriously difficult to evaluate for, and that's why we try our best to make sure that an algorithm is very robust, very strong, and is generalizable on the front end before it gets out into the general population. So we want to ensure when an algorithm is being trained, it has a very wide range of diversity in its training data, because once it gets into the general population, being able to assess these very, very large sets of data for evidence of bias, whether that is, an algorithm that performs worse on a different or a certain type of scanner, or on a certain imaging protocol, or a certain patient population, whether that is patients of a certain age, race, sex, gender. It's very difficult to evaluate that scale of data between different hospital systems, and on a very large number of algorithms. And again, algorithm bias can result in a worse performance on certain patient populations, and in a field as high stakes as healthcare, these can result in patient harm. This sends a patient down the wrong treatment path, false negative. A patient could be erroneously sent home with an urgent finding. So it's not hard to imagine how these biases that exist in algorithms, if they go unchecked, could result in patient harm, and could potentially deepen health disparities if they're disproportionately affecting one patient group. And so this task of evaluating for algorithm bias falls in a little bit of a gray zone, because when you think about monitoring the performance of an algorithm, you would think that this would typically fall to the vendors to be able to monitor how well their tool is performing once it gets into the real world. We want to have post-market surveillance once it has been deployed. But a lot of the information that would be important to determining algorithm bias is not readily available to the AI vendors. So patient race, patient age, patient location, a lot of the other things that could potentially be sources of bias are not readily available. Some of those might not be immediately within the DICOM header, and would require a deeper dive into the electronic health record, which vendors don't have ready access to. And so at that point, is this a responsibility of the clients to be performing these large scale audits on every algorithm that they buy, for every case that an AI application is being used for? And are they going to be having to devote a significant portion of their time and resources to ensuring the quality use of these applications that they have in practice? And reasonably, the clients should have safeguards in place for the use of their AI applications to ensure that they're working properly, and make sure that the people who are using the applications have been adequately trained. But it would be a substantial ask, and it's a substantial burden that would have to be considered if, in addition to the safeguards that they already have to put in place, they would also are responsible for monitoring the performance and for evidence of algorithm bias as well. And when we think about algorithm bias, the most obvious case would be thinking about two extremely disparate patient populations and two extremely disparate patient groups. But healthcare itself is becoming increasingly decentralized, uh, or contrarily, it's becoming increasingly centralized, that we have radiology groups that have different imaging centers that sometimes cross state borders in the United States. They have different hardware between different imaging centers, and they can serve very different patient populations. So thinking of our own institution, that we have imaging centers that are in a part of the state that are more affluent, more urban, that have newer imaging equipment. And then we also have referring hospitals that send images from more rural areas that have older and some more outdated imaging equipment and some antiquated protocols. So even within our own healthcare setting, we have a wide variability in the types of images that we receive and the types of patients that we treat. And so this is where we get into our project and how we took initiative to attempt to screen for algorithm bias within exams in our own institution. But before we get to that, we'll talk a little bit about radiology and global health to give some background. So radiology has had a substantially rising role in the field of global health. That's largely due to the increasing access to radiology technology and the decreasing cost of the technology to perform these exams. So radiology, artificial intelligence, and low and middle and their use in low and middle income countries is very distinct to how radiology AI is being used in the United States and in the EU. That AI automation is being used to meet the needs of the radiology communities and the health communities in these regions in a different way. And one of the ways that's very interesting is that the AI is given a higher level of autonomy, that in the United States, all of the applications that are used for computer-aided detection that assist the radiologist in diagnosis require human oversight. So everything that's being done by the AI, the human user is the final say and is the expert that signs off the report and is responsible for the final report. In some countries that have deployed tuberculosis screening algorithms, these function at a higher level of autonomy, that they screen chest radiographs and they are able to screen out negative exams, so normal exams, and only the suspicious or positive exams are sent for review. And we currently don't have anything that's functioning at that level of autonomy in the United States. So it's it's an interesting it's just kind of an interesting feature that because of the needs, the needs in different healthcare settings, these healthcare systems in low and middle income countries are able to leapfrog us in a way, and are going to have more experience with a more autonomously functioning artificial intelligence application. So it'll be interesting to look to those countries and those systems to see how their experience with that goes in the future. And then finally, one of the big features that has made radiology and global health have such a boom in the past decade has been the increasing accessibility of teleradiology. That high resource centers can serve as host sites and have relationships with health systems in low and middle income countries, and have a longitudinal relationship with these health systems without having to have someone physically on site. And that's something that we have been very proud to do here in Birmingham, that we have two partner hospitals that we'll discuss on the next slide. And for the past few years, we've been able to integrate their exams into our existing workflow. And with that, since we've been able to integrate exams into our existing workflow, we're able to use all of the tools that we use on all of the exams that would be performed here in our hospital on exams that were performed at our partner hospitals in Cameroon, Ethiopia. So here we have our two partner hospitals, Mbingo Baptist Hospital in Cameroon and the Soto Christian Hospital in Ethiopia. So our question was, do our radiology AI applications perform as well on studies performed in Cameroon and Ethiopia as they do on exams performed at our hospital in the United States? So just as a comparison of the two cohorts, at the U.S. hospital, this is a high volume center. We have numerous scanners throughout the system or throughout our health system. So multiple scanners in our emergency room, multiple imaging centers, multiple ERs throughout the region, each that are each having their own CT scanner. We have multiple subspecialized radiologists. The majority of what we read every day is read by a subspecialty trained radiologist. We also have a relatively high imaging utilization, which I imagine would probably be the case at most hospital systems in the United States. We have a very low threshold to get imaging, particularly in the outpatient setting and in the emergency department. And we're also a trauma and cancer center. So we have a large volume of trauma cases and also a large volume of cancer treatment cases. For the international cohort, each of these hospitals have a single CT scanner at each hospital, and each are served by a single general trained radiologist. So an overall lower imaging volume, just because of the lower capacity for performing imaging studies, but also generally a lower ability to or a lower capacity to read those studies because they're served by only a single radiologist. Contrary to practice at the U.S. hospital, these exams receive a thorough workup prior to getting scanned on the CT. They receive a thorough physical exam, thorough history. There's laboratory workup prior to being scanned, and that is by the nature of having only a single CT scanner is treated less as a commodity and more as a trouble or as a problem solving tool. And similar to the U.S., both of these centers function as trauma and cancer hospitals as well. So when we were evaluating the AI applications, we chose to focus on a FDA-cleared intracranial hemorrhage detection algorithm. This is a computer-aided triage type application, so it's CAD-T application. So the way that this particular algorithm works, it evaluates the images for a non-contrast CT head for studies that are deemed as high suspicion for intracranial hemorrhage. It flags these studies on the work list. It also provides a heat map, which guides the radiologist user to the part of the image that was deemed most suspicious for intracranial hemorrhage. And this is all integrated into our workflow. So the same way that this would function on an exam that's performed in UAB, the AI application functions the same way on exams that were performed in Cameroon and Ethiopia. So all non-contrast head CTs performed at the Cameroon and Ethiopia hospital systems were reviewed by a single reader during our study period and were compared with the AI results. We determined true positives, true negatives, and false negatives, and used this information to determine recall, precision, and accuracy, and compared these values to performance from the U.S. hospital system. So from January 1st to July 31st of 2024, 486 non-contrast CT heads were performed at the African hospitals. And this was an average of about 69 per month, with a range from 29 to 110. There was a wide range in recall, which, like we discussed, is another term for sensitivity. And this ranged from 0.55 to 1.0 for the African hospitals, and this was compared to an average of 0.83 and this was with an average of 0.83 compared to the U.S. hospital average of 0.95. And the precision, which is also the positive predictive value, ranged from 0.74 to 1.0 with an average of 0.92. And this was actually higher than the precision of the U.S. hospital, which had an average of 0.78. So we'll give some more context to those numbers here, but we'll start by talking about that lower recall that we observed. And this was particularly more pronounced at the beginning of the study. So when we were talking about recall at the beginning of the AI literacy course with the introduction lectures, recall is affected by, or is an expression of sensitivity. So you want a high recall, an algorithm with high recall to be highly sensitive to positive findings. So you want a very low number of false negatives. Uh, so that's especially important in this case because when we have false negatives, that affects the triage portion of our computer-aided triage. So these exams are not moved up the list for us to read more urgently. So the more urgent studies might be read within an hour or two. The non-urgent studies might have to wait several hours, 3, 4, 6 hours, maybe 24 hours, which can affect time to treatment for these very urgent cases. So in January, we noted a relatively high number of false negatives, which contributed to the difference in recall that we see here. And this trend continued in February, where we saw an even lower recall compared to the United States, or to the performance at the US hospital. So it was at this point that we reached out to the vendor because we were concerned that there was evidence of algorithm bias. And so this is an example of what these exams looked like. So these were all none of these exams were flagged as positive by the AI application. So in the exam on the left, we can clearly see that we have a calvarial fracture, orbital fracture with intraparenchymal hemorrhage. In the middle image, we have a more subtle subdural hemorrhage along the right calvarial convexity. And in the far right image, we have a much larger subdural hematoma with midline shift and likely entrapment of the ventricles and evolving hydrocephalus. So none of these studies were flagged, which was concerning to us, and we wanted to figure out why that was. So we were concerned that there was evidence of algorithm bias, and it was at this point that we made a communication to the vendor, and we did a further audit of these flagged studies. So it was a disproportionate number, disproportionate number of false negatives. And when these exams were performed, it was noted that this was not necessarily an error with the application itself, with the image evaluation. This was an informatics error that these studies that were being performed at the African hospitals were not as consistently being sent to the AI vendor for analysis. So this was addressed on the informatics side. An adjustment was made in late February, and we continued with the study. So in March, you can see that the recall increased significantly. So we were much closer to the performance of the U.S. hospitals. And in April and May, it actually exceeded the recall at the U.S. hospitals. We did have another drop in June, and so this was something that we took very seriously, and we wanted to see if there was going to be a trend in the following month. But in the following month, recall did come back up and was comparable and actually slightly higher than compared to the U.S. hospital. And just by the nature of the volume of cases being performed at the African hospitals being relatively lower, we do expect a little bit more variability in recall and precision, just by the nature of having a smaller denominator. But it is something that when we see a sustained drop over time, we want to take that very seriously and see if there's a pattern going on. So precision, on the other hand, was higher at the African hospitals almost every month, excluding May, during our study period, and this was a significant finding. So this reflects a lower false positive rate, and we had a few theories for why that was that we'll get to in the discussion. So we did note a differential performance of the AI application during the different months of the study period. So there were a significantly higher number of false negatives, which results in a lower recall during the first 2 months of the study period. But after intervention, after communication with the vendor, we were able to get this issue addressed, and recall improved substantially. It was comparable to the United States hospitals. Precision was significantly higher than it was at the U.S. hospitals, which was a bit of a surprise to us. Uh, but it does make sense when you consider that there was a lower rate of or there was a lower rate of false positives because the number of exams with pathology was much higher at the hospitals in Cameroon and Ethiopia than it is in the U.S. hospitals. So there's a much higher pretest probability, uh, and these patients typically have a much more thorough clinical workup before having exams. So that might be something interesting for the vendors to consider, that these algorithms seem to do better when there's a higher pretest probability and there's a higher likelihood of positive findings. So this we did note significant findings and significant differences in our study, especially initially before we had addressed the informatics error. Uh, but this required substantial effort on our part to be able to audit these exams. We had to add additional quality steps, added an intentional review of reviewing each of these studies and comparing the precision, recall, and accuracy between the different exams. Required vendor communication. So even on this relatively small scale of comparing two very disparate patient populations and two very different imaging environments, it still required a substantial amount of work to be able to detect and prove this difference in performance. And this complexity will only become will only make things more challenging as more AI applications are integrated, and more AI applications are integrated into various steps in the diagnostic process. So it's very important to be aware of the potential for algorithm bias, to have infrastructure in place to audit and assess for these differences in performance, and to be aware of the harm that algorithm bias can cause to the patients that we do serve. So ultimately, it is our responsibility as the radiologist using these applications, interpreting these scans, and signing the reports to know how to use these applications, know how they make their decisions, being able to recognize false positives, false negatives when they occur, uh, and being able to communicate with vendors when we are suspicious that there may be errors and that there may be evidence of bias. This is all critically important for us as we enter the future of radiology and the world of AI. So our take-home points from today is that AI has the potential to revolutionize healthcare and may have its greatest impact in low-resource settings. But algorithm bias it can be a very difficult to detect and insidious pitfall for clinical AI, and has the potential to result in patient harm. We were able to detect a differential performance in the initial phases of our application. And it's important to note that this was not a problem with the vendor's product. The vendor's product performed exceptionally well, sometimes better on the data from our partner programs in Cameroon and Ethiopia than it did on the U.S. data. But because of this informatics error, it did result in a differential result. So even if this isn't a issue with the algorithm itself, ensuring that our systems are not resulting in differential performance is an important step in mitigating algorithm bias. And then finally, the vendor and client collaboration is critical to ensure the continued quality of clinical AI performance. And this is something that can't be overstated, how important it was to be able to audit these findings and to have this partnership with our vendors. That ensuring quality is very much a team sport. That we have to take ownership of the performance of the applications and take ownership of our own abilities as a radiologist and being able to communicate with the vendors and triage problems when they occur and make these sometimes small, sometimes large adjustments is very important. So I have my references here. We are right at time, and I would be very happy to take any questions if you all have any. All right, I have a couple of questions here. All right, so our first question is between workflow improvement versus computer aided detection, which category of AI do you think will be most helpful for radiologists to meet the increasing volume and complexity in the US? So I pretty firmly believe that at this stage, the workflow improvement applications are making the biggest impact in terms of radiologist quality of life and overall turnaround time and it is a difficult question that the workflow improvement I think are the ones that are most well received. The computer aided detection tools are very important, and as they continue to improve and as they are more widely integrated, I think will make a substantial impact. Uh, but I know at least from my daily workflow, I'm very happy when I'm able to use an AI application that makes my day a little bit easier. Uh, so getting the workflow improvements of getting back even a minute per case or even 2 minutes per case, 30 seconds per case, if it's something that makes my or increases quality of life and decreases cognitive load, can make a substantial impact to just overall quality of life. And then the second question we have here is how big is the potential difference in impact uh, or how big is the difference in potential impact and how does that change for US versus low and middle income countries? Uh, so it's been a very stepwise process currently. Uh, we are still looking to see what's going to be the silver bullet. We, in my opinion, haven't quite reached the tool that is the real game changer. Uh, that's going to really open us up to the next stage in the practice of radiology. Uh, but these workflow improvement tools, it's a relatively small impact. Like it's like I was saying, it's maybe a minute per case, maybe it's 30 seconds per case, maybe it's 2 minutes per case. Uh, but it's these very small steps that I think improve practice over time. But on the other hand, I think it is it's a different set of needs in low and middle income countries. So these tools that maybe provide more diagnostic support uh, for general radiologists when they're interpreting more subspecialty exams or more complex exams, that's not something that I am as concerned about in my practice because we have such a large number of subspecialty trained radiologists. So I think it's a very different perspective between practices in the U.S. and low and middle income countries. We have another question about our work with breast cancer. Uh, we did not have any projects with breast cancer in this specific project. Uh, but there is ongoing research for difference in performance of CAD in breast cancer detection. uh, between patient populations in the U.S. and EU, and then underrepresented populations internationally. So that's another very interesting area of research. Uh, but I'll admit that's not an area that I'm as familiar with. All right, well, that has brought us to the end of our fourth day. Uh, I am I'm very excited to get to wrap up this course. Tomorrow we're just going to have our course review, and then we'll have our final lecture with Dr. Omer Awan, and he'll be talking about the AI or application of AI in healthcare and looking into the future of what AI augmented healthcare will look like. For those of you that are going to be attending SABI in Washington, D.C., please come visit us on Saturday for the Too Cool for School session, where we'll be highlighting some of our vendor partners, and we'll also be having an AI workshop roundtable. And uh, yeah, thank you all so much for attending the course. This has really been a fantastic course this year. We've gotten into some subspecialties and topics that we've not discussed in this course before, in our 5 years of doing the AI literacy course. So this has been a really wonderful session. Appreciate all of you and your support, and we'll look forward to seeing you all tomorrow.